Thank you, sir, for the excellent presentation. Now I am invited to Dr. Smita Bhat ma'am. It is my pleasure to invite Dr. Smita Bhat ma'am, a respected physician actively involved in the diabetic management and her clinical researches. Her dedication to improve patient outcome make her a valued member of the medical community. And her topic is Meta-Flammarion, the missing link between arthritis, obesity, and diabetes.
Check. Check. Am I audible at the back? The last two, am I audible? Good afternoon, everyone. I'm so happy to be back in the holy city of Varanasi. Very grateful to Asutosh ji and team. And I'm very, very honored indeed to deliver the Savita Bajaj oration. I bring greetings from Mangalore and a warm invitation. You're always welcome to visit. So what we'll be doing in the next 15 to 20 minutes, we'll start with a case scenario, which is very similar to what you see in your clinic every day. Briefly, I'll revise some important terms. Then we'll define meta-inflammation, talk about how it is different from our classical garden variety inflammation. Most important, I would like to explain the adipose immune axis and how it exacerbates meta-inflammation. A word or two about meta-inflammation and arthritis. And then finally, at the end, we'll see what we as clinicians can do to impact outcomes. Now, when I present this slide, if this patient looks familiar to you, I'd like you all to raise your hands, please. This man is Mr. Peter. You can see he's 54 years old. He's heavy. His BMI is high. His waist circumference is high. He's hypertensive as well. He's a known case of gout, osteoarthritis, diabetes, hypertension, and MASLD too. This is what he's on right now. Etoricoxib, metformin, insulin, glimepiride, amlodipine, and hydrochlorothiazide. This is what he is on when he comes to you. He's unhappy. He has recurrent attacks of swelling of the knees, and he has attacks of gout. Now, in today's world, we won't be surprised if you find, am I audible? Yeah. You won't be surprised if you find that he has Googled his symptoms and he decides to meet 3 doctors. It is also not surprising, but it is a little bit disappointing that each of these doctors examines Mr. Peter only with the point of view of their specialty. What does the ortho do? Please lose weight, take painkillers. What does the diabetologist do? He adds a gliptin. He says, check again in 3 months. Physician may be a little bit broader view. What does he do? He says, cut down on red meat, add febuxostat. But what has gone wrong? Has something gone wrong here? Let's just see. Many things went wrong. The first thing was, none of these esteemed doctors actually checked HSCRP. None of them measured adiponectin. And I'm going to tell you why all these are important later. Nobody ever thought that the gout and the osteoarthritis might be related. And finally, and this in my mind is a big blunder, on one side you're thinking he has gout, on the other side you're giving hydrochlorothiazide. That doesn't make sense. So these are 4 of the many, many mistakes that happened with this patient. Let's look at his labs. I'm not going to read this out. Have a look at it, and I would like to tell you, I am aware, dear friends, that some of these tests are not available everywhere, and some of them are expensive, I do agree. However, many of these tests like CRP, like ESR, all these are available to us. We can do these tests very easily. Uric acid, of course, we can do. Adiponectin, in our center, we do. It's a little bit expensive, 2,600, but it's not that it's not available anywhere. These are his labs. This I would like you to have a glance at. Please observe, looking at his parameters, he very nicely fits into metabolic syndrome. You agree? His imaging, okay, you're not surprised he has osteoarthritis, both knees, all that is okay. A DEXA scan shows a worryingly high amount of visceral fat. Look at his values. He has very bad dysglycemia. He has worrying lipid profile as well. Before we go on to managing this patient, let's go on to the pathophysiology of what exactly might be going wrong. The thing is, and this is where we went wrong, we are not dealing with 3 diseases here. we are dealing with one disease which is affecting 3 organs. What has happened, the key villain here is the visceral fat. This visceral fat triggered inflammation, and that inflammation, what did it do? It went to the pancreas, destroyed the beta cells. It went to the liver, deposited fat, and it went to the joints and eroded the cartilage. One disease, my friends, just one disease. I just want to, I'm sure many of you know many of these terms. I want to revise a couple of them. Adipokines are basically the messenger of visceral fat. That's a broad term. Mismatch disease is what happens when, the environment is changing very fast, and ideally our genetic makeup would adapt to this change. But when the genetic makeup does not keep pace with the environmental changes, something called mismatch disease happens. Subcutaneous adipose tissue, you're all aware, this is a relatively benign bystander. What does it do? It causes, gives some insulation. It has some functions, endocrine functions. On the other hand, visceral adipose tissue, he is the bad guy. What does he do? This visceral adipose tissue, my friends, is what is mainly linked to metabolic syndrome, to inflammation, and to all the problems that we're dealing with Mr. Peter. Now we come to the key of this talk. It's meta-flammation, also called meta-inflammation. It is so important that each one of us has this in mind as we look at each one of our patients. What is it? It's a chronic, low-grade systemic inflammation. It is not induced by an infection or let's say an offending agent from the outside. It is triggered by nutritional overload. It's persistent and fundamentally maladaptive. Most important, this is what I need you to remember. It is the primary link between obesity and this vast epidemic of non-communicable diseases that we all are facing. How is it different from the garden variety inflammation? It's fairly simple. The trigger here is not an acute infection, it is nutritional excess. This is not a high-grade acute inflammation like what we see normally. It is a low-grade chronic inflammation. Importantly, acute inflammation is driven by the neutrophil, whereas this meta-inflammation is driven by the macrophage. This acute inflammation heals soon. Meta-inflammation is unresolved and maladaptive. So these are the, let's say, these are the differences. In other words, on the whole, inflammation, the classical inflammation contributes to healing, whereas meta-inflammation militates against it. What is this adipose tissue immune axis? It's very, very important for all of us to know, for nutritionists, for physicians, for diabetologists to know. So let me just delve into it in a little bit of detail. Very, very simply, this is how I shall put it. Firstly, there is a nutritional overload. Where does this excess energy go? It goes and gets stored in the adipose tissue. Therefore, the adipocytes hypertrophy. They hypertrophy. Finally, the capillary blood supply cannot keep pace with this hypertrophied adipocytes. Therefore, there is necrosis. And this necrosis, what does it do? A simple reaction to necrosis is it triggers inflammation. This releases a cytokine storm with many consequences, one of which is blockade of the insulin receptors, which leads to insulin resistance and which leads to this whole cascade and whole painting of metabolic syndrome. The worst part is it's a vicious circle. Insulin resistance increases obesity, obesity further increases nutritional overload, and the whole thing goes on and on and on. See, so let's go into it a little more detail. The adipocytes expand, they become hypoxic, and when they become necrotic, they start spilling free fatty acids and something called DAMPs, that's damage-associated molecular patterns, into the circulation. This is probably something we should be aware of. It's called the crown of thorns. Normal healthy adipose tissue has macrophages, which are the M2 macrophages. During inflammation, this is replaced by the M1 macrophages. So they come here, and let's see what happens to two things, the necrotic adipocyte along with the M1 macrophage. Sorry. So it's fascinating. I'm so sorry, 1 second. Okay, yes. So just think, in every cell there's this factory, and it is so beautiful to read about it. This NLRP3 factory is sitting in every cell. Who turns on the switch of the machine? 3 things. It could be the DAMPs, which I mentioned just now, reactive oxygen species, as well as saturated fats. Once this machine turns on, caspase is activated. Let's forget the complexities. Basically, what happens is IL-18 gets converted from inactive to active state. And this IL-18 has many deleterious consequences. It goes and acts on almost every organ. It goes to the pancreas and muscle. Here it increases insulin resistance. It goes to the liver, where it promotes MSLD. It goes to the heart, where it promotes atherosclerosis. And it goes to the kidneys, where it accelerates the progression of diabetic kidney disease. Now, this is such a beautiful statement, and I would like you to remember this. When the storage capacity of the adipose tissue is exceeded, it is no longer a reservoir for excess energy. It becomes a pathological endocrine organ. That is what we should remember. This storage, what we thought was just a tank of storage, now becomes an active pathological endocrine organ, and it releases cytokines and free fatty acids into the circulation. So, okay. This is not the only thing that's happening. This is not the only thing that's happening in meta-inflammation. This excess nutrients, animal fats, red meat, all these things, what do? They decrease the microbial diversity in the gut, and all of us know the importance of the gut microbiome. It alters the firmicutes and the bacteroids ratio, making the gut microbiota less able to produce short-chain fatty acids. So what happens? What happens here is the mucus layer gets eroded. And therefore, think of all the gut bacteria which are sitting in the gut and being prevented from entering the circulation. They start going through this leaky gut. It's referred to as a leaky gut because of the gut microbial dysbiosis. There is, let's say, leaking of the lipopolysaccharides of gram-negative bacteria from the gut into the circulation. And so this results in what is called a continuous low-grade metabolic endotoxemia. It is frightening, isn't it, to think of all these endotoxins circling in our blood continuously. And that is what is triggering most of the inflammation that we're talking about. Let us now talk about the connection between meta-inflammation, arthritis, and pain. So were the concepts clear so far? Is there anything that I should clarify? And then I shall proceed. So we've talked about what we are interested in as physicians. We are interested in diabetes, fatty liver, atherosclerosis, all that. But almost, and I'd like you to raise your hands here, all the patients of diabetes that you see every day in your clinic, how many of you say that more than 50% of them have some kind of joint pain, have some kind of body ache? I would raise my hand. How about you? See, almost all your hands are raised. What I'm saying is, we shall not be able to relegate arthritis to the province of the orthopedist alone. It's our concern too. I would like you to wonder, to reflect, why inflammation versus the pain of arthritis? I myself have done this. I myself have heard this. The minute you go to a doctor with joint pain, the first thing that I said that I heard was what? What's the first thing you tell your patient? Lose weight, lose weight, lose weight. Yes? So, but the thing is, if it was just weight that was causing osteoarthritis, why would the hand joints be involved? Evidently, there is something else. I'm so sorry. What is this something else? It's not just arthritis. They also have various aches and pains which sometimes we can't explain. Fibromyalgia, chronic body aches. And they're dismissed and told it's functional, you're too stressed. We are all guilty of having said that to our patients' friends, isn't it? But there is a connection between what we are seeing as physicians. That adipose tissue, which we thought was not really related to the joints, it is a bridge between the inflammation and the joint. It is the connector which quietly is adding to the process, to the pathogenesis of osteoarthritis. Long ago, unfortunately, many orthos are still saying this, it was considered a purely mechanical failure, arthritis. But now we know arthritis could be just a local manifestation of a systemic meta-inflammation. It's very interesting. It's because, not so much because of the joint, but because of the nerve that is supplying the joint. So there is something called an adipose neural crosstalk. Let's remember what I said about the mismatch hypothesis. So genetically, we were kind of programmed to do something, but gradually as our environment became less healthy, with more access to not so good nutrition, with less access to exercise, our genetic makeup did not keep pace with it. And therefore, one of the many mismatched diseases that we see as physicians is osteoarthritis. Remember, this is because not just of weight increase, but because of a chronic systemic inflammation. I would like you all, take your left hand or your right hand and palpate your knee. Just go below the knee and palpate that soft thing there. Everyone, come on. You can palpate your own knee. Don't feel shy. Just below, in front, just below the patella. Just below the patella, there's this innocent looking pad of fat. You may or may not even notice it. Did you know it was there? Sir is saying, I don't have pad of fat there also. Sir is very healthy. What to do? See, many of you have this infrapatellar pad of fat. All of us do actually. And it is not just, it's not just cushioning. It is in fact the major villain in arthritis. What does it do? It's one of the neck sites, one of the foci of inflammation, and it continuously bathes the joint in numerous cytokines. Just think of the effect that would have. What is the effect it has? So if you imagine that you have an abrasion on your arm, anything that touches it will pain more. In other words, what is happening because of the cytokine storm, of the cytokines bathing the joint, they sensitize the nerves and thus make the nerves very sensitive to even normal everyday movement and thus causing pain. This is called peripheral sensitization. But my friends, the cytokines don't stop here. What do? They cross the blood-brain barrier and they go and bathe the spinal cord and the brain as well. And they decrease the pain threshold there. So it's not just mechanical arthritis, it's the inflammatory markers causing peripheral sensitization and central sensitization, and in the bargain, damaging the joint. There are some chemicals which we call the language of sensitization. Substance P is actually the local nociception. NGF, or nerve growth factor, is what causes the so-called nerve pain. And BDNF, the brain-derived neurotropic factor, this is what causes central sensitization. And finally, there are these things called adipokines, which I did mention before. Leptin, it's supposed to be the satiety hormone, but here, in terms of inflammation, it's not the good guy. It's pro-inflammatory, and it directly drives the nociception of osteoarthritis. Unlike adiponectin, which seems to protect the joint. In other words, a higher leptin-adiponectin ratio is detrimental. It's considered a clinical biomarker. So this is all very well. This is stuff we learned when you were a student doing first MBBS in biochemistry, but you will ask, how can I help my patient? The first, and we have very nutritionist friends in our audience, the first, of course, is dietary interventions, and I'm sure you'll all agree with me. The healthiest diet that we can talk about is the Mediterranean diet or the DASH diet. Both of them are useful because this is found to actively lower interleukins and C-reactive protein. Additionally, this Mediterranean diet in itself is good for the gut. It improves the gut microbial diversity and decreases gut dysbiosis. And this is something which, how many of you get more than 6 hours of sleep every night? Raise your hands. Every night. Hey, you people are lucky. But not all of you raise your hands. I'm with you who didn't raise your hands. Circadian rhythm, why is it important? Because less than 7 hours of sleep, it tends to worsen inflammation, of course, but it also increases central sensitization. So how do we map our therapies to the problem? The first thing, we remember you said that visceral adipose tissue is the prime villain. So you give therapeutic measures which can address that. You can give GLP-1 RAs, you can give metformin to a certain extent, and you can prescribe the Mediterranean diet. For local infrapatellar fat inflammation, you can give intraarticular adelmidol and hyaluronic acid. I spoke to my orthopedist colleagues. They don't really do this yet. It might come in the future. And for central sensitization, tell your patient to sleep well and give something called systemic PEA, which is palmito something acid, which I forget, but you get the basic idea. See, I just want to tell you something. We prescribe drugs for dyslipidemia, hypertension, obesity, dysglycemia. But what I would like you to keep in mind, dear friends, is when we are choosing these drugs, it is important that you choose drugs which might address inflammation as well. Therefore, when you're treating hypertension, be aware that calcium channel blockers, now this is from a Nature Rheumatology review, all this information, calcium channel blockers are known to worsen the pain of osteoarthritis. Beta blockers, on the other hand, seem to decrease the pain a little bit. ACE inhibitors have numerous good effects, so yes, prescribe them bravely. But absolutely do not ever prescribe hydrochlorothiazide to a patient who is already having hyperuricemia, because it decreases the uricosuric effect and increases hyperuricemia. So once again, what would you choose? Beta blockers, ACE inhibitors, rather than calcium channel blockers, rather than thiazide. Calcium channel, yeah, so ACE inhibitors and AR. Absolutely, that's what I've mentioned, ACB and AC inhibitors and ARBs. ACE inhibitors and ARBs, absolutely agree with you, sir. What about the drugs for diabetes? What will you choose? So, use biguanides. Metformin has numerous effects unrelated to just decreasing the blood sugar. It is anti-inflammatory to a certain extent as well. But today's hero, GLP-1RAs, have so many good effects, and now it looks like they decrease inflammation as well. See, they are anti-inflammatory, they are anti-catabolic. Sometimes I wonder, should we all start prescribing GLP-1RA much more often than we really do? So I would like you to reflect on what we are doing. Let us not put a bandage on a fracture. Let us go back and fix the bone health. Let us address the cause. So the first thing we were worried about is visceral adiposity. Let us address that by weight loss, Mediterranean diet, GLP-1RAs, exercise. So here what I'm doing is, when I decrease visceral adiposity, I am shifting the macrophage population in the fat. I'm shifting it from the dangerous M1 to relatively healthy M2 macrophages, first. The second thing, you remember I talked about that factory where NLRP3 sits and it causes interleukin activation. So let us cut it off right there and inhibit NLRP3 and therefore decrease interleukin and therefore decrease inflammation and all its myriad side effects. And finally, now this is still, you can also consider, you have these cytokines themselves. You can address them directly. You can give cytokine inhibitors. This is still experimental. So I love this sentence. It says, and I got this again from that review, advanced therapeutics aims to decouple obesity from its comorbidities by directly silencing the immune microenvironment of adipose tissue. So he's fat, but let that fat not cause further harm is what we're trying to say. Shall we go back to Mr. Peter? Do you remember his face? Yes. What did we do? So now I'm giving him semaglutide. His weight is coming down. His HbA1c is coming down. It also reduces something called the NF-kB, which is again, let's say, an inflammation promoter. I'm giving him EMPA. So again, there is some weight reduction, a little bit. But there's also, very importantly, NLRP3 inhibition, CV protection, and it improves MASLD, as you all know. Definitely, and I'm sure many of my physician friends agree with me, I would never give an NSAID to a patient with diabetes, hypertension, not safe at all. Of course, you would stop hydrochlorothiazide. Maybe I'll give some uricosuric drug like allopurinol. And we should remember that our target of uric acid is stricter in a patient with both osteoarthritis and gout compared to with a patient of one of these alone. And finally, not negotiable, eat healthy. What we say is eat clean and train dirty. In other words, exercise until your muscles cry, but eat healthy. See what happened to Mr. Peter after all of this. It worked quite well. His body weight came down by 12 kgs. His HbA1c came down significantly. But what is important to us is, so did his HSCRP. His interleukin, his uric acid, his pain score for the arthritis came down. And see, you will know that for us as physicians, we are worried about the lab values. Patient was worried about one thing only. What was that? His joint pain. His pain came down, so he is happy. And his gout flares almost became 0. So patient is happy with us. What do we see in the future, friends? At least if I can remind you to look at every patient you see as a boiling kettle of inflammation and to address that inflammation first, my job is done. But I would also like you to keep abreast with what might be happening very soon in the future. So we were saying that M2 is healthy, M1 is unhealthy, but now they're going beyond that saying. We are no longer dividing macrophages into M1 and M2. We are talking about metabolically activated macrophages, and that is what we are trying to address. We are looking for more sensitive, more specific, and more economical markers of bioinflammation. And finally, see, all these things were secreted because they were transcripted from a gene. So the ultimate step is addressing the gene itself. So this is what we are planning to do. Thank you very much for your kind attention before lunch, and I really appreciate your presence before lunch. And pardon? Colchicine is useful. It's used for acute pain relief, but not in inflammation. Now, I'm not sure if it's useful in meta-inflammation as such, but it is useful in gout. So, pardon me, sir. Good question. Yes, sir. So, sir has asked a very relevant question. The adipose tissue cells first undergo hyperplasia, and this is a good response. So, as long as they're hyperplasia, it still continues to be healthy adipose tissue, which is, let's say, insulin sensitive, and which is a storage organ. But still, you're continuing to overload the fat. Then it becomes hypertrophy. I'm not sure. At least in the references that I saw, you're saying that any reference to when it becomes hypertrophy. I am not sure. I'm not sure of the answer to that, sir, but I will find out. That's a very good question. I'll find out. I'm not sure if there's a limit as such. So, any other questions? Absolutely. Absolutely. Because, sir, if I can just go back quickly to that picture where you're asking if addressing adipose tissue impacts insulin resistance. No? Yes, yes.
Whether it should try to negate the lipotoxic effect.
Okay, okay. So,
insulin sensitivity improvement in the face of hyperplasia.
I get your point. And logically, the answer would be no. Because when does the inflammation begin? Please look at this picture. Can I have the picture? You took off the slide? I want the slide actually. They took off the slide. It's okay. See. Dr. Tamanash, what happens is, yeah, if you can look at this slide. See, the adipose tissue sitting in itself is not causing problems. What happens when the adipose tissue undergoes necrosis? Only then does it start the chain of inflammation, and that happens only when there is pathological hypertrophy. So I would say that suppose you start treating in the phase of hyperplasia, what you are doing, you're preventing further progression into hypertrophy, but you're not necessarily bringing down the glucotoxicity or the blood glucose. So that's a logical answer to what you say.
Madam,
Sir.
Since we are treating the patient quite in a late stage,
Agreed.
like already when there is ectopic fat deposition,
Agreed.
osmotic fat is here.
Agreed.
So giving the GLP-1 or sweet
Yeah.
how does it impact? Because the process has already been.
Yes, yes, sir. So if we thought that the only impact of GLP-1 was on bringing down the glucose and decreasing insulin resistance and decreasing the weight, what you say, I would have agreed. But sir, GLP-1 analogs have been proven to have an anti-inflammatory effect as well. And as I mentioned, the whole key to this process is inflammation. So in fact, if I can just take you to that slide, that is the whole point of prescribing GLP-1. Yes. See, GLP-1, apart from controlling glycemia, weight, what is most important is they are anti-inflammatory. And therefore, yes, there is a role even when we see them later. That's a very good question. Now, yeah. Okay. So my first thing is about physiotherapy. I personally and with all my patients have had an excellent experience with physiotherapists. I believe it does good. Now, when I send a patient to a physiotherapist, it's not just that he's doing particular exercise only for the muscles around the knee. He's telling the patient how to exercise, how to, on the whole, bring down his BMI, how to increase the muscle, decrease the fat. So it would absolutely have beneficial effects. So that's your first question. And cycling, I do agree, because you know why specifically cycling for this population, you're giving a good aerobic exercise which is relatively knee friendly. And most of these patients do have knee osteoarthritis. I don't have a chairperson only. I agree, and at that point, I would expect Dr. Tamanosh only to pick this up, because by now so much damage, we have to agree there is a mechanical component as well. Enough damage would have occurred. But I'm thinking, see, when did we start giving GLP-1 RAs? If we start prescribing relatively earlier, as they become more available, more cheap, maybe it will have a different effect on the TKR rates as well. And if I find out, the first person I'll tell is you.